Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a routine topical phaco of a cataract with grade 3 nuclear sclerosis. Let us observe this surgery. This is the main incision with a 2.8 mm steel keratome on the posterior aspect of the limbus. And now in this case I have done two side ports. My plan is to use bimanual irrigation aspiration. This is the side port on the right side, and this is another side port on the left side. The side ports are about 3 clock hours away from the main incision. And now an air bubble is being injected into the anterior chamber. Beneath this air bubble, trypan blue dye is applied over the anterior capsule. Care is taken so that the dye spreads over all parts of the anterior capsule. And now this is a bit of adrenaline to see if the pupil dilates little more, and in this case adrenaline helped the pupil dilated a little more. The dye is washed out, and then 2% SPMC is injected into the anterior chamber. The SPMC is also applied over the corneal epithelium, and this improves visibility. Apply SPMC only over the cornea. It's not necessary to apply a large amount of SPMC so that it spills over onto the sclera. And now this is a rhexis with a utrata forceps. I'm planning a rhexis of about 5.5 mm, and in this case the rhexis was very satisfactory. This is a nice circular rhexis. And now hydrodissection is to be done. This is a 27 gauge cannula attached to a 2 cc syringe. The fluid is injected at 2:30 o'clock, then injected at 7:30 o'clock, and the nucleus is tapped, and then the nucleus is rotated. So the nucleus has rotated nicely. Some more visco is injected, and now is the time to go into the eye with the phaco handpiece. This is Ophth Cataract 3 phaco machine. This is easy tip 2.8 mm from Ophth, Switzerland. The tip goes bevel down, some superficial cortical lens matter is removed, and then the nucleus is rotated clockwise as well as anti-clockwise. And now watch direct chop. The tip is buried into the substance of the nucleus, and if the nucleus is of this consistency, you don't go beyond the center, and slice the nucleus into 2 heminuclei. Hold again and chop. This free nuclear fragment is emulsified. If the cataract is soft like this, we need not make all the fragments and then start emulsifying. We can just chop, make free fragments, and eat it off at that very moment. And this is the last fragment. At this time I am removing the chopper to make the SE more stable, and in this case we see that most of the cortex has come out. This is the beauty of spinning the lens for few times, clockwise as well as anti-clockwise. Most of the cortex gets loose and it comes along with when we remove the epinucleus. And now some cortex is there at 6 o'clock and some cortex is there at 10 o'clock and 9 o'clock. This cortex is hydrated so that when we aspirate it comes easily, and it comes really easily because the cortex was hydrated very nicely. The posterior capsule is polished by the irrigating cannula only, and this is hydroimplantation of a single piece monofocal hydrophilic acrylic intraocular lens. By a push of the left hand instrument, the lens goes into the capsular bag. Now the lens is dialed and it is placed nicely. And now this is injection of moxifloxacin. Now the side ports are closed, hydrating corneal stroma on either side. The main wound is constructed in such a way that it doesn't require any hydration. Now this is the final lavage of the anterior chamber. At this time, any visco sticking to the corneal endothelium is removed. The anterior chamber is nicely formed, and then the integrity of all the wounds are checked by a cotton-tipped Johnson bar. Few drops of moxie is applied and the case is concluded. Thank you very much for your attention. Hope this video will encourage you to do cases very meticulously. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence.